Ladies and gentlemen, boys, girls, and NBs, welcome back to the Smooth Brain Society. This is another episode where we'll be going over some of the great work being done at the British Neuroscience Festival, or some of the great work which is being showcased at the British Neuroscience Festival. And in the first episode, we spoke a little bit about the BNA, so the British Neuroscience Association, and a little bit about the outreach work the Liverpool Neuroscience Group is doing. But we had a third organization which we did not actually talk about in great detail, although we did mention them, and that was the Brain Charity. And we needed to start off this episode by giving them their flowers, so I'll let Beth go ahead and sort of go and talk a little bit about what they do, who they are, and yeah.
So the Brain Charity is a national UK charity that supports anyone affected by neurological conditions, whether it's something well known like dementia or epilepsy, or one of the 600 plus rarer conditions like trigeminal neuralgia or Alice in Wonderland syndrome. They help people through practical support, emotional counselling, and social activities, making sure no one feels alone after a diagnosis. What makes them particularly special is around 40% of their staff are neurodivergent or have neurological conditions themselves, so everything they do is rooted in lived experiences. They're based in Liverpool since 1993. They've grown into a vital service that helps thousands of people across the UK every year, and the need for what they do has only grown since the pandemic. And as part of the British Neuroscience Association Festival of Neuroscience, the guest speakers from Liverpool Neuroscience Group will run interactive sessions on a variety of topics relevant to brain health during April, May and June coffee mornings. So get yourself on the website and have a little look and see if you want to get yourself down there. And our Neuronights, first Neuronights comedy night last week was all the funds was raised to go to the Brain Charity. So thank you everyone who turned up. And we've got another one on the 24th of April if you're free to go at Leaf Bold Street. Tickets are a £5. Everything goes to the Pain Relief Foundation.
Awesome. Brilliant. All right. And without further ado, we'll introduce our guest. So today's guest, we're talking to Professor Tony Marson. He is Professor of Neurology and Executive Dean of the Institute of Systems, Molecular and Integrative Biology at the University of Liverpool. He leads the Liverpool Epilepsy Research Group and is an honorary consultant neurologist at the Walton Centre NHS Foundation Trust in Liverpool. So welcome, Tony. Pleasure to have you.
Yeah, it's a pleasure to join you.
So I guess the first question which I ask most of my guests is sort of what was your journey into getting into your field of epilepsy research? Like what sort of made you take this path?
Yeah, so I'm a clinician at heart, and I pretty early on in my training, probably in medical school actually, I discovered that neurology was probably what I wanted to do. So I was kind of fascinated by the neuroanatomy and the kind of logical approach to trying to work out, whereabouts in the nervous system is the problem, what is it, and what is it that we can do to help.
Just to stop you, could I quickly clarify what's the difference between sort of like a neurologist, a neurosurgeon, and a neuroclinician? All these things, are there like sort of differences between them?
Yeah, a good question, because people often think I'm a neurosurgeon, which I'm not. So it in medicine we kind of have two main routes. One is to be a physician, and the other is to be a surgeon. So I'm a physician. So and I've gone on a track where I see people with a whole range of neurological conditions, and my main focus is on epilepsy. So my main job is seeing people in my clinics and giving them kind of diagnoses and advice and about their management.
So, because you said epilepsy was sort of like your specialty, could you give me an idea of what all comes under epilepsy?
Yeah, so having decided I wanted to do neurology, I got some junior doctor's jobs and was exposed to epilepsy at a time when there were quite there was a lot of interest in developing new treatments and new approaches, and for a lot of neurological diseases. So this is back in the very early 1990s. We didn't have much in the way of treatments, which altered the disease process. So we didn't have disease-modifying treatments for things like multiple sclerosis, which are now common day treatments, and we were developing an epilepsy surgery program, so brain surgery for people with epilepsy. So there was a lot going on. There was a kind of an inspirational leader, David Chadwick, who turned out to be my mentor for a long time. And I think that your career path is often very influenced by what you're interested in, but also the people around you and how they motivate you and stimulate you and mentor you. And I had a really good exposure to epilepsy as a young clinician, and then as a junior researcher, and I've spent most of my clinical and my research career in epilepsy. And you asked me earlier a bit about what epilepsy contains, and one of the fascinating things about epilepsy is that it is so kind of heterogeneous, and there's a lot going on, and a lot of questions that we've got to answer, and a lot of things that we need to consider in clinical practice. So we say that people have got epilepsy when they are susceptible to having epileptic seizures. And one thing to say is that seizures are really a symptom of something going on in the brain. So whilst you might think about epilepsy being one condition, it's actually thousands of different conditions that manifest as seizures, and we're on a journey to try and understand the biology of those conditions. And the other area of heterogeneity is that there are lots of different types of epileptic seizures, ranging from episodes where people might get just a strange feeling, maybe a feeling of deja vu, butterflies feeling in their tummy, to episodes where people might go blank, stare, lose awareness and behave automatically, through to episodes that everyone would recognize as an epileptic seizure, where somebody will collapse and be stiff and shaking on the floor for a few minutes. And the other area of complexity is that it can start at absolutely any age, and it can be something that starts shortly after somebody's born, and it can start later on in people's lives. And because our population is changing, we've got more older people in our population now. It's actually more common to diagnose epilepsy in older people than it is in children. So I think often we think of epilepsy as being a disease of children, but it's not. It's something that can start at any age, a bit more common in children than that kind of middle life, but actually it's much more common now in older people, as we're accumulating damage to our brains from strokes and circulation disease and head injuries and brain tumors and so on. So whilst you might think epilepsy is just one condition, why is that so interesting? Well, actually, it's really fascinating. It happens at any age. There's lots of biological processes going on that we need to understand, and there is also massive impact on human life. So it's a really stigmatizing condition. There's still a lot of myths around epilepsy. So people with epilepsy still feel stigmatized to some extent, even in what we might think of a more modern society, a more progressive age, and it impacts on employment, education, fertility. It has massive ramifications. So it's a really broad and fascinating area to be involved in.
That's amazing, Tony. So the absolute, you say heterogeneity of epilepsy. Is there a specific subtype of epilepsy you particularly research, or is it all epilepsy, or is that just not possible?
Yes, so I'm an adult neurologist. So and again, the way we kind of carve things up in health services is you're someone that sees children up to the age of 16, or you're someone that sees adults from the age of 16 or 18 onwards. So I'm an adult neurologist. So I tend to see people over the age of 16. So that people may have had a diagnosis in childhood, and then they get transferred to me as an adult neurologist. But yeah.
Yeah.
I've lost the track of the question there. Sorry.
No, I know you talk about different types of epilepsy. So I think you've got like myoclonic seizures and other types of seizures. Is there any that you particularly like to research more? I know as a neurologist, I'm sure you'll see all sorts, but in terms of research, is there a specific one that you think you like to research more or requires more research or you just find particularly interesting?
Yeah. So the kind of questions we've focused on in our research program is thinking about early epilepsy. So not necessarily thinking about types of epilepsy, but thinking about where people are in their journey, and that point of diagnosis and the treatment choice at the diagnosis is really mission critical, because you've really got to get it right at the start, because that's your best opportunity to get people back to education, back into work, back driving and functioning in society. And sometimes the eye is drawn to the complex, and we'll probably talk about that later. But I think from a kind of a public health point of view, we do the best thing for society when we get it right at the start of someone's journey, and make sure that they're not disadvantaged by not having their condition as well controlled as it might be. And practically, we think about two main types of epilepsy, particularly in adulthood. And when we think about epilepsy where seizures start in one place in the brain, and we call that focal epilepsy. And it's probably about 2/3 of people in adulthood have got a focal epilepsy. Seizures start in one place. And we have kind of paradigms and treatment approaches for that. And then there's about 1/3 of people that have got what we might think about as being a generalized epilepsy, and during for those people, seizures start on both sides of the brain at the same time. And the cause of that is probably mainly genetic. Although we're still on the journey to really unpick the genetic architecture of the epilepsies. And then there's a much rarer group of epilepsies which will tend to present in childhood, some of which are really severe and associated with learning difficulties and other significant health problems. We think, again, that's a group of conditions that we think of as largely being genetic. These are the conditions that you may see on the news. Conditions, for example, there's a condition called Lennox-Gastaut syndrome and a condition called Dravet syndrome. They're the conditions that we might use cannabis for, and that's something that's been on the news quite a bit. But they're really quite rare types of epilepsy.
Yeah, I think last week we briefly spoke about HM and off on the after side of the memory side, but he had epilepsy, didn't he, where they had to cut part of his temporal lobe, I believe, or his entire temporal lobes. Is that usually where the epilepsy starts in the temporal lobes, or can it be anywhere in the brain?
Yeah, so epilepsy tends to start at the front of the brain, so either in the frontal lobe or the temporal lobe, and I think we readily recognize temporal lobe epilepsy as a condition. Most people think about, well, do I have an aura before my seizures? I think it's pretty common parlance, isn't it? People understand that this notion of an aura, and with temporal lobe epilepsy, the sort of auras that people might get is kind of deja vu, strange taste, strange smell, butterflies feeling in their tummy. And those symptoms are actually coming mainly from the inside bit of the temporal lobe, something that we call the hippocampus, and in front of that there's something called the amygdala. And we recognize that bit of the brain is susceptible to scarring. So one of the most readily recognized types of epilepsy is temporal lobe epilepsy, so seizures that are coming from the temporal lobe, and it is generally coming from that inside bit of the temporal lobe. And for a long time, we've been aware that sort of epilepsy often doesn't respond well to medication. We can't stop the seizures with medication, and so surgery might be the best option for that person. So can we cure their epilepsy or reduce the severity of their epilepsy by cutting out their temporal lobe? And most of that surgery is actually focused on this hippocampus inside bit of the temporal lobe, and some units do an operation whereby they only take the inside bit out, and others do an operation where they take the whole of the temporal lobe out on one side. And interestingly, people can function really well without one of their temporal lobes. And often you're taking out a temporal lobe that wasn't functioning very well. So we often worry about memory, but actually, if you're taking out a damaged temporal lobe that wasn't really functioning very well from a memory point of view, then the other side's taken over anyway.
Yeah, but just not both of them. Otherwise,
yeah, take both out. It's a disaster. You end up with somebody with zero memory.
Yeah.
This comes into the question of brain plasticity, right? So, are these surgeries performed in sort of younger kids as well, and do they seem to recover better than if such a surgery where you had to take out half your temporal lobe was performed in an adult?
Yeah, so the surgery is better performed younger. So a lot of the surgery used to be done in adults when it could have been done in children. Increasingly, much more epilepsy surgery is done in children now than it's done in adults. And brain plasticity. Brain plasticity is a really good reason for that, because we're worried about memory. So we want the other side to take over in terms of memory function, but we might also be worried about speech, particularly if we're operating on a dominant hemisphere. So if we're operating on the left-hand side of the brain and you're right-handed, then we need to be very careful not to damage the speech center. But if there is any damage to the speech center, if the damage is done as a child, then there's much greater opportunity for brain plasticity to do its thing, and for speech to develop in other bits of the brain, either in a slightly different bit of the temporal lobe or on the other side. And we will see people in adulthood who have kind of had damage to their left temporal lobe. They're right-handed, but the speech has moved over to the other side because the epilepsy was causing a lot of disruption, or there was damage to the left temporal lobe, which meant that speech moved over to the right.
That's really interesting. I had a question from a part which you said earlier, which has been burning. You had said that in adults, the adult case you see about a third seem to have a genetic component to it. That was the one where seizures can start at any region of the brain. It's not a focal point one.
That's right.
Is that the one which is more common in children because it's genetic?
Yeah, so generally focal epilepsies are more common in general, but the generalized epilepsies, they start in childhood and adolescence mainly. So once somebody's over the age of 25, it's pretty unlikely that their epilepsy, if it's starting then, is a generalized epilepsy. So in adulthood, we will more commonly diagnose focal epilepsy than generalized epilepsy, but in pediatrics, they will diagnose a lot of generalized epilepsy. And the generalized epilepsies have a number of different patterns. So most people will have probably heard of kind of absence epilepsy, or sometimes historically was called petit mal epilepsy, where children just have brief blank spells. And that's a common type of epilepsy to present in childhood. And then we have generalized epilepsy that can cause tonic-clonic seizures. So tonic means stiff and clonic means shaking. So again, something that we'd all recognize as a seizure. And then one of the particular types of epilepsy that starts in teenagers is something that we call juvenile myoclonic epilepsy, and that includes jerks, so jumps and jerks, which are myoclonic seizures, as well as tonic-clonic seizures. So we label the epilepsies, or we give them a name based on the age that it starts and the type of seizures that people are having. And we have to do that because at the moment we still don't understand the biology. So if we could say this is epilepsy caused by gene X, then we'd say it's epilepsy caused by gene X. Because we don't have that, we still have this quite complicated classification, which is much more based on kind of clinical features rather than what we know about the biology. Hopefully in a number of years' time, we will really understand the biology much better, so that we can label it better, but also hopefully have a better treatments, because our treatments aren't as good as we would like them to be at the moment.
So as it stands, there's no such thing as one epilepsy gene which you have, kind of.
No. So we've all been working together around the world for about 20 odd years now, trying to unpick the genetic architecture. So through our research projects, we've collected information and DNA from patients, and that DNA can be sequenced to obviously look at their genetic makeup, and then we can pool all of that information, because we need information on thousands and thousands of people to answer these sorts of questions. And I think what we thought when we started this was, well, we'll probably find a few genes, and it turns out that we're not going to find a few genes, and for a very small number of people, it's just one gene that's at fault. For most people, it's multiple genes, and it's a polygenic condition. So it means that you've got a number of gene problems added together, and they cause the epilepsy. So everyone's working hard on unpicking the different genes that go wrong to cause the epilepsy, and working on what are called polygenic risk models to help us work out who's at risk of epilepsy. And so it's we're on a journey, and it's a much more complicated journey. The problem with complicated journeys is it takes you a long time to get the answer, but it also costs millions and millions and millions of pounds or dollars or whatever to answer the questions, and trying to get that money out of funders to answer these questions is really quite challenging and tricky.
Yeah, but it affects so many people. I don't even know the percentages it affects, but I think
it's about 1% of the population have got epilepsy. So it's a common condition.
Yeah.
People don't often talk about it. So you may know people that've got epilepsy that haven't told you they've got epilepsy, but it's a huge problem, huge burden to individuals and society, and we don't spend enough money on it at the moment to try and answer the questions.
So a quick question very back to the genetic things. So is it more likely you'll have generalized epilepsy if your parents have it, or is it because the genetics are just so, there's not one gene, it's so mixed?
Yeah, there is an increased risk. So for most people, what am I trying to say? So there are some families where the generalized epilepsies run strongly in that family, and some of the focal epilepsies actually. But so having a parent with epilepsy increases your risk, but it only increases your risk by a small amount, unless you're someone in one of these families where there's a really strong history of it. And one way of trying to explain it is, some genes from mum, some from dad, and added together they cause the epilepsy, which is probably why we don't see it a strong inherited pattern. So whilst the genetic study, the epidemiology tells us, these are genetic conditions, it's rarely one gene.
One gene, and it's kind of push it. There was a study, I believe it was done at King's. I think it was with Mark Richardson, where he looked at imaging in family members, and I think it was EEG, and he found very similar patterns. But some people did have epilepsy, and some of the relatives had very similar patterns, had the exact same brain signals. And that to me is like, okay, so they've got similar brain signals. What is it that's almost pushing it over? I don't know if you can shed any light on that, because I found that fascinating when I read that.
Yeah. So exactly, and that again, that highlights what we were saying earlier, that seizures are a symptom of a brain disorder, and what is that brain disorder? So that research was telling us that the brains of these people, these families, that are built differently. They look a bit different to the general population, but not all of them are having seizures. So what is that underlying brain problem, and what is it, as you say, that tips them over the edge to also have seizures as part of that? And we're on the journey to unpick that. And it might not all be genetic either. There may be that genetic environment interaction which is putting some people over the edge and making them have seizures. So there's a lot of unanswered questions, I'm afraid.
A lot of layers just to throw even more on you. I can feel like not borderline frustration that it's 1% of the population are affected, and it's some people just don't even, I wouldn't even know that it was that high. I only know briefly because I'm a neuroscientist, and my supervisor, Professor Simon Keller, also works in epilepsy. Do you think and you said recently before, like it's to do with stigmatization. What is the stigma that people feel like they can't share it? Do they worried? What's the biggest fear? Is it the fact that they might not be able to drive, might lose their job? What scares them so much, and how can we overcome that as well? So two questions.
Yeah, it's a good question. I mean, people are frightened by epilepsy. So if somebody has a seizure in the street, some people will rush and help, others will run away because it's a very frightening thing. And there is people can jump to conclusions. This is somebody that's on drugs or something like that. That there's the historical perception of there's demon possession and lots of cultural history there, isn't there, around seizures and epilepsy, which we need to break through. And a lot of this is about education, isn't it?
Yes. Yeah, it's pretty. So education is what we need more of to.
Yeah. And it's a bit of a catch-22, isn't it? Because if people with epilepsy were able to declare their epilepsy and be more open and discuss it, then that would break taboos as well, because people would realize, actually, I know somebody with epilepsy, and they're a very sensible, rational human being that's got a medical condition just like many others. And I think that there is a challenge here with a kind of an episodic condition, because it means that it's hidden. If you've had a stroke and you've got a weak arm and leg, everybody can see that, and it's a fixed disability. But for something like epilepsy, people look completely fine, and then they're not fine for a few minutes having a seizure, and so it's a very hidden disability that people are frightened of.
Do these seizures then get worse over time? That's the other thing for epilepsy, which I wanted to ask, because, like you said, they happen, and then they could potentially be, people could be performing normally again, and then they can happen again. So yeah.
So what often happens is that kind of the epilepsy will declare itself with a seizure, and then you go through kind of a period of time working out how bad is it. Because some people will then have very infrequent seizures. Some people then go on to have quite frequent seizures. And once you've gone through that period of epilepsy kind of declaring itself and its pattern, often it doesn't deteriorate, but there are a small number of people where the epilepsy gets worse over the course of time. And the $1 million question is, what is that process? What is going on in those brains that we can actually interfere with and stop, so that we can stop people from developing a severe and treatment refractory epilepsy. And that's probably a really important question for the people that might end up requiring epilepsy surgery, or the people that've got really bad epilepsy where we just can't do an operation. What is that process? What can we do to stop people getting into that state of having a severe drug refractory epilepsy?
I know that the SANAD trial, you were looking at some of these drugs as well. Could you talk us through that a little bit about the SANAD trial? I think that's a good example of.
Yeah. So the SANAD stands for Standard and New Anti-Epileptic Drugs. So we've been through a period of developing a whole new generation, possibly two generations of what we now call anti-seizure medications, and have previously been called anti-epileptic drugs. And we've got some really, kind of practical questions like, okay, which of these drugs should we be using first line, and for which patients? And if you're the NHS or National Health Service or a funder of healthcare, you don't only want to know which one's best, but you want to know which one gives you the best bang for your buck. So you want to know which one's cost effective. So we've tried to answer these questions in our SANAD trial. So what we've done is we've run a big randomized controlled trials within the UK health system, and we've recruited people with newly diagnosed epilepsy, and they've been randomly allocated to one of a number of treatments, and we then follow people up for a number of years and find out what happened to them, what happened to their treatment, what happens to their epilepsy. And when we're treating a long-term condition like epilepsy, we do need to follow people up for a few years to answer that question. We can't answer that question in just a few weeks. And our treatment paradigms in epilepsy are one level are pretty simple. So we think about, have people got a focal epilepsy? If they've got a focal epilepsy, then we use drugs like carbamazepine historically, and then lamotrigine as first-line treatments. So the SANAD trials were comparing carbamazepine in the first set of trials, and then lamotrigine in the second set of trials with other treatments. And what we find is that at the moment, the best drug to start for most people with focal epilepsy is lamotrigine, because it's controls seizures, it's really well tolerated, and it's cheap. And for the so focal epilepsy from a new diagnosis point of view is fairly simple. For the generalized epilepsies, for a long time we've known that valproate is an effective treatment, and the question then is, okay, how does valproate compare with the newer treatments, or perhaps the other way around, how do the newer treatments compare with valproate? And in the most recent trial, we compared valproate with medicine called levetiracetam, and we find that valproate is the most effective treatment. So we've got really good information from randomized controlled trials as to what should be the first line treatments if we're just thinking about how well does the drug work and how is it from a side effect point of view. But of course, because we also need to take a step back and think about what else is going on in people's lives, and half the people that we're treating here are female. And what's really important to be thinking about is the impact on contraception and fertility and the outcome of children. And what we know about sodium valproate is that if babies are exposed to it in the womb, there's about a 10% chance that they'll have a major malformation, maybe a problem with their spine or an arm or a leg or something, and also about a 30% chance that they're going to have a significant reduction in their IQ. So it's really important that women don't take sodium valproate whilst they're pregnant. So we've got this really, really challenging scenario for women, whereby we know what the most effective treatment is, but we want to avoid that treatment in pregnancy. And of course, most women, when we make a diagnosis of epilepsy, they're not thinking about starting a family at the same time. But that decision we make when we start treatments will potentially influence what treatment people are on when they become pregnant. So at the moment, we've got this really difficult position whereby we almost effectively deny women the access to the most effective treatment because of our fears about it in pregnancy.
Mm-hmm. And does that have longitudinal effects? So if you stop it 2 years before, would you still have those percentages, or is it still unknown?
Yeah, so we think that it's safe to stop. If we stop it, it's safe once women have been off it for 3 months. There is a caveat to that. So it's all got a bit more complicated in the past 2 years because there is some information from animal data, in particular, that there might be an effect for men taking sodium valproate. So if men are taking sodium valproate and their partner gets pregnant whilst they're taking it, there's a possibility that their children will be affected. And on top of that, there's a problem that so sodium valproate has what we call an epigenetic effect. So it has an impact on the DNA, and there's a risk that there's concern that men or women could take sodium valproate and have children, and those children could be affected by the sodium valproate because of an epigenetic effect, and then their children, even if they're not exposed to valproate in utero in the womb, might be carrying this genetic epigenetic effect down the generation. So there's a concern in the background that sodium valproate might be changing the genetics, which is then passed down the generations. We don't know whether that's a real thing or not, but it's a worry in the background, and so we've got some really urgent questions to answer. Is there really effect on children born to men taking sodium valproate? And is there a transgenerational effect caused by epigenetics? And it's really difficult in the consultations at the moment, because we have to have a conversation with men and women about these things, but we've also got to tell them we don't really know whether it's true, whether some of these things are true or not, but we've got to warn them about the risk. And consultations and conversations with people are really easy when you know what the risks are, when you're saying there's a possible risk, but yeah, we've got to manage this possible risk. That's really frustrating and really difficult. So we've got to answer these questions, crack on and do the research to sort this out.
Yeah, and because most of the epigenetic stuff in terms of men is relatively recent, because because I've done work in my lab about alcohol and the transgenerational effects of alcohol if men are drinking before conception. And yeah, you see these sort of effects, but there's no like large studies, not enough studies to sort of confirm and be like, yes, this is a problem. It's more like this could likely be a problem. And I understand, that level of frustration as someone who has to talk to patients or anybody who comes in, be like, there's evidence for it, but
I mean, one of the models for autism is to give mice high doses of high dose valproate exposure during development in the womb, and then offspring of those mice will also have these autistic traits. So there is this kind of an animal model, but the doses used to create that autistic model are much higher than we use in human practice. So we've got this kind of alarming possibility in the background, but we don't know whether it's true or not.
Can I ask with regards to valproate, because you said it's for generalized epilepsy was the one which you had said it's really good for. Valproate's been around for ages. How come no new drugs have been developed which sort of have been better over the time?
Yeah, that's one of the really frustrating things. So we're working hard around the world to develop new treatments, but we've not been able to develop any treatments that are better than what we had already in terms of controlling seizures. So valproate remains the drug that is best at controlling seizures, and it's probably worth just taking a going down an alley, if it's like just talking about sodium valproate. So and drug development in epilepsy. So one of the challenges in epilepsy is that we still don't understand the mechanisms properly in the brain. We got very excited in the 1990s when we learned a lot about hyperexcitability in the brain, but we realized we've got so much more to learn about mechanisms, and there was a period of time when we didn't really understand how valproate worked anyway. We knew it worked, but we didn't understand how it worked. And I don't know whether you know, but it was actually discovered by accident. So people were doing, I think some French, I think they were in France, they were doing experiments on cats that they made epileptic, and they were trying different drugs, and they found out that all the drugs seemed to be working, and they scratched their heads and thought, oh gosh, it must be the solvent that we're using to deliver the drugs. So they were using valproate as a solvent. So valproate was discovered completely by accident as a highly effective treatment. And despite our advances in science, understanding of mechanisms, we've still not been able to develop a drug that is better than sodium valproate at treating seizures for people with generalized epilepsy. And we've got similar stories for focal epilepsy. And I think one of the really important things to highlight is that all of our medicines at the moment are really treating the symptom, a bit like taking an aspirin for a headache. They treat the seizures, but they don't treat the disease. So what we desperately need in epilepsy is treatments that alter the basic biology, treatments that are actually disease modifying in epilepsy. We've achieved that in multiple sclerosis to an attempt, to an extent rather, and I guess we've got some rare instances where we're treating genetic diseases. through new technologies that are coming through. We need to be able to do this for common diseases like epilepsy. What are the common mechanisms, despite this heterogeneity? What are the common mechanisms that we can attack to modify the disease, reduce its severity?
I thought we'd spend this last sort of part talking about something which you mentioned earlier, and what your work is generally around is around the early sort of detection or early epileptic detection. And some of the things which you said made me think how hard it actually is, because you said anything from staring off into blank space for a little bit could be someone having a seizure. So how does it work? What would someone need to know in terms of being able to, I guess someone needs to self-identify that it's potentially a seizure before they even come see you. So yeah, how does all this work? How difficult is it? Because it sounds really, really hard.
Yep. So it's complicated, and I guess one thing to say is it requires experience, but we recognize patterns, and one of the things that medics are trained to do, and they might not realize that they're being trained to do it, but they recognize patterns. So when you've seen things lots and lots of times before, you recognize it very quickly, and you also work out what doesn't fit the pattern and probably isn't a seizure. So if you've only seen this once or twice, then you're going to struggle to be certain. Whereas if you've seen it hundreds of times, then of course you're going to be more confident in what you're dealing with. And if somebody's just had one episode, it can be really difficult to know whether it was a seizure or not. And just think about our job as a clinician. There are two really important things. One is getting an eyewitness. So we need eyewitness descriptions of events, and that's important because for most seizures, people lose awareness, so they've got no knowledge of what happened. So the only way to get a good story is to have an eyewitness. The other thing is that seizures are stereotyped. So while seizures can be really quite varied, when an individual is having seizures, their seizures will tend to be the same thing every time. So clearly you can't make a judgment about things being stereotyped if you've only heard a story of one thing, but often you'll hear a story of somebody that's had a number of episodes, and if the story is of stereotyped events, then you're increasingly confident that they are seizures, particularly if they are a pattern that is consistent with seizures. But one of our jobs as a clinician is to work out what is a seizure and what's not a seizure, because there is that uncertainty. So people go to see their GP, they go to the emergency department, somebody raises the question, well, was it a seizure? And then they get referred to our services to answer that question. And on average, we need to see about 3 people in those clinics to see one person that has actually had a seizure. So there is a lot of uncertainty about that, and it's our role as clinicians in this space to kind of resolve that uncertainty, and we will be able to relatively confidently say it wasn't a seizure, it was a seizure, or I'm not sure, let's wait and see, and if there are more seizures, we'll get a description, and then we'll become more confident about it. But the other thing to say, I guess, is that there's an error rate. So clinicians get into trouble when they make a decision and they're not prepared to reevaluate that decision. And in this space, there is an error rate. So we need to continually reassess and consider, is the diagnosis right here? Are we on the right track? Are we doing the right things?
Yeah, it makes sense, and good the fact that you can say yes. Basically, is it you saying like, "Yeah, we got it wrong," but that's all part of the process. And some people aren't happy to say that, I guess. Next, could we maybe move on to you were a plenary speaker at the British Neuroscience Association festival. Could you maybe give us a little bit of a taster or preview of what you're going to be talking about there?
Yeah, and I think we've already talked on some of that already. So I'm going to be talking about treatment choice in newly diagnosed epilepsy, how we design trials or clinical trials or experiments to answer those questions, and talk about the evidence that we've got so far that drives clinical practice around the world in terms of treatment choice in focal epilepsy and treatment choice in generalized epilepsy, and some of those trade-offs that we might make about benefit and harm when we come to make decisions.
Yeah. Now, that sounds super exciting. I look forward to hearing you talking about it way more. And yeah, could you just, I guess, because we're coming to the end, would you have any final thoughts? Any things that we did not cover, which you think we should cover?
I think we covered a lot of ground, actually. I think what's really important to highlight again is that we need to be all working together to understand mechanisms so that we can develop some treatments which modify disease. And one of the things we didn't talk about was the fact that about a third of people with epilepsy, we can't control the seizures. I don't think we made that clear enough during the presentation, actually, on reflection. So we say we've got a disease affecting 1% of the population, which is a lot of people, and a third of those people, which is still a lot of people, are having seizures that we can't control. So we desperately need to understand how we stop that happening.
That's a lot. So just 30%. So like, was that 0.33% of the population are just wandering around with uncontrolled seizures?
Yep.
That is a wild number. Just put that in perspective. Gosh, I don't even. It's growing so quickly. But how many people are in the UK now? Is it 70 million?
About 70 million, isn't it? Yeah.
About 70 million. So that's about 3 million, maybe just under 2.5 million, possibly wandering around with uncontrolled seizures.
Yeah, so it's less. It's
no.
It's
250,000, not
250,000.
250,000.
So embarrassingly off. Sorry, 250,000. A coffee yet, please ignore. It's not 250,000 people. Sorry, fast this morning. Apparently, is it? Don't let me do that again.
Yeah. We estimate there are about 600,000 people, just over 600,000 people in the UK with epilepsy at the moment. So it'll be about 200,000 people, probably a bit more with uncontrolled seizures. But it's a lot of people.
And so that's still a lot. That's a city size. It's actually a size of a big city.
I was about to say Glasgow is about 600,000 people. So yeah, that's like the entire city of Glasgow having seizures. Yeah, sometimes when you put things in percentages, they seem a lot smaller than what they actually are. Do you think doctors should use big numbers instead?
Yeah, it depends on the message you're trying to give. I mean, you don't want to scare the life out of people, but absolutely right. We need to get the message over, and I think that there's a lot of kind of neuroscience where looking at this from a clinical point of view, where we haven't made the arguments well enough about getting the funding in. And I think dementia have done really well. This recently, motor neuron disease are on a trajectory, but there's a lot of burden from neurological diseases that we need to address, and I guess this chimes in with the kind of brain health message. And we realise that kind of cancer and other areas have kind of done really well with their messaging, but actually brain health and poor brain health is a much bigger problem for society, and particularly in a post-industrial society like ours, where the capital is in the brain health of our population. So we need to be much better with our communication from a neuroscience point of view, and flying the flag for more resources into not only research but also into the care that we provide for people with brain and neurological conditions.
Yeah. So we need more salesmen. That's what we need. We need more marketing. We need better marketing.
Yeah, it's like marketers.
Well, we need more marketing, but we need to be more effective in the way that we come together and the way that we do things as well, don't we? And of course, the British Festival of Neuroscience is a great place for us all to come together and discuss how we want to change the world.
Awesome. I think that's a great note to end on. So thank you, Tony, for coming on. Thanks, Beth, again. And do you have any final message for our listeners as well, Beth?
Get yourself to the British Neuroscience Association, and if not, get yourself to all the public engagement events happening around Liverpool. There are tens of events going on. If you go on the BNA, bring your own brain, then you can have a little look. So we've got something for everyone.
Of course. And like we said at the start, the Brain Charity keeps doing things throughout the year. So there's events and things going on throughout the year. And we're going to keep everything up online as well, too, so that people who can't make it also have access to as much information as we can give. So awesome. Take care, everybody. And yeah, thank you. Bye.